Hi everyone, this is Aashin Shah. So I'm going to be talking a bit about an approach to sleep disorders. It's a very big topic, so I'll try and keep it short. So I'm avoiding all the physiologies and the actual history one needs to take in an actual clinical setting. I'll be focusing just on the sleep history part of it, and so this should work as a framework and not a set guideline. So let's just start with the definition of sleep disorders. So sleep disorders involve problems with the quality, timing, and the amount of sleep, which result in daytime distress and impairment in functioning. Now, the first time I read it, I was like, impairment in functioning could like mean something as simple as just losing concentration. Anybody want to say what impairment in functioning would mean to them?
Inability to or difficulty in performing activities of daily living.
Right? Yeah, but think about like, did anybody think about this? Yeah. Can anybody guess what this is?
Maybe cognitive function and executive function, like difficulty taking decision, maybe.
This particular photo is about the Chernobyl reaction, the explosion that happened. It's basically sleep deficiency, another 3 Mile Island explosion at the nuclear reactor plant, and the Exxon Valdez oil spill, as many of you might be aware of. And all of these, along with multiple vehicular accidents and everything, had a history of sleep deprivation, sleep deficiency, or insufficient sleep the night before. Now the Exxon Valdez itself around cost us $6 billion. Now imagine like it costs so much more. Like sleep isn't just a normal thing, right? It needs to be taken seriously as well. And something more relatable, there was also a study in which it said that the adenoma detection rate was lower in physicians who had an emergency on call, who were on call the night before. And so just to summarize the importance of sleep, there's lots of important function of sleep. It's it balances the hormones, the ghrelin and leptin, which if you're insufficient sleep, you tend to be more hungrier compared to if you're well rested. It also supports healthy growth and development, and it also plays a role in puberty and fertility. Our immune system also relies on sleep, and the ongoing sleep deficiency is linked to an increased risk of heart disease, kidney disease, hypertension, diabetes, and even stroke, and increased risk of obesity as well. One study of teenagers showed that with each hour of sleep lost, the odds of becoming obese went up. And these are just some parts like why sleep is important. And thus, like we always wonder how much sleep is actually important. When do we term something as sleep deficiency? So there have been many definitions, many guidelines of how much sleep do we need, but this is by far like the latest one which I could find. And as you can see, it varies so much based on the individual and according to the age group he is in, ranging all the way from 14 to 17 hours in a newborn to 7 to 8 hours in an adult. For all of us around here, 7 to 9 hours of sleep is recommended. However, 10 to 11 hours or even 6 hours may be appropriate as well. And so classification of sleep disorder is important because there's so many, like specifically there's 60 specific diagnoses of just sleep disorders. Like the first time I saw it, I was like, it can't be right. But there's just so many sleep disorders. And they've been majorly split into 7 major categories of sleep disorders. Insomnia, the one we all know of, sleeping related breathing disorders, central disorder of hypersomnolence, circadian rhythm sleep wake disorders, parasomnias, sleep related movement disorders, and again other sleep disorders. And the other sleep disorders includes any sleep disorder which has overlapping features, as well as certain which there's not enough data about them. And it varies all the way from as something as simple and common as jet lag to something as fatal familial insomnia, which basically is a very fatal disease, as the name says, and you could practically die because you cannot just sleep. And they're just scary to think of it. And so just to summarize all of it, so insomnia again has 3 distinct types, that is short-term, chronic, and other insomnia disorders, which do not fall into either of those categories. Then there are sleep-related breathing disorders. Again, there's central sleep apnea, obstructive sleep apnea syndrome, sleep-related hypoventilation disorders, Then there's also central disorders of hypersomnolence, and that is basically narcolepsy and even the sleeping beauty syndrome, where the person sleeps for like 23-24 hours a day easily. Then there's the circadian rhythm sleep wake disorders, which includes jet lag and which basically affects is the misalignment between the environment and an individual sleep wake cycle. And there are parasomnias, which are again divided into non-REM sleep and REM sleep disorders. And they're basically undesirable physical events or experiences during entry into sleep, during the sleep, or during arousals from sleep. And then there are sleep related movement disorders, which is restless leg syndrome is the most common one. And then the other ones. And so if you're lucky enough, the patient will present to us with a chief complaint of sleep, but mostly it is an underlying disorder which may not just come up clinically. But if a patient complains of sleepiness, it mainly falls into three categories. There is insomnia, I cannot sleep, or excessive daytime sleepiness, where the patient feels he feels too sleepy during the day, or there's movement during the sleep. Now, daytime sleepiness may be underestimated because of its insidious onset and chronicity. So my focus in this further slides would be to just focus on excessive daytime sleepiness compared to insomnia and movement during sleep, because that is more like, it is very straightforward actually. So starting with the history, like we all say history is so important, right? But the first thing to do is actually determine if the patient is actually sleepy or he has fatigue, lack of energy, or weakness. And since the terms are so confusing and we use it interchangeably, we might like to ask like definite questions to determine what the patient exactly means. So the questions could be like, do you feel sleepy during the day, or do you fall asleep at times when you do not want to? Like these questions like are particularly target sleepiness. Like if the patient says yes, he's more likely to be sleepy. And if the patient is more likely, you are inclining towards tiredness or fatigue, then you ask them, do you like energy to go about your daily activities? Do you lack, sorry, or do you feel physically or mentally exhausted? The interesting questions are here as well, like does your problem bother you more if you sit to read for an hour, or do you go out shopping for an hour? And it's important to ask the patient directly, like what is the single most important problem for you? Is it sleepiness, tiredness, fatigue, or lack of energy, or which of those interfere with the ability to accomplish what you would ideally want to, and which is the one that you would like to address effectively? So what I like to think of it as, like I would say sleepiness. mm, when the person is sleepy, it's more related to sedentary activities compared to when it is fatigue. The patient would actually want to do it, but is unable to do it because he's tired. So in the evaluation of excessive daytime sleepiness, the history is directed at, again, refining the complaint of sleepiness, like what exactly is the patient experiencing, and identifying the potential causes. So we should always specifically ask about the propensity to fall asleep in low stimulus situations, such as long drives, just reading, watching television, talking on the phone. Like if any of these are present, then excessive daytime sleepiness is more likely. So good sleep history. So what do you guys think a good sleep history should include? Anyone?
How the room is, if there's any distractions in the room.
Yeah, perfect. So along with that, you just want to find out the detailed information about the symptoms, like what exactly are the symptoms of the disturbed sleep and the duration of the symptoms. Is it acute or chronic? If it's acute, it is more likely to be like a precipitating factor, any medication changes, or a recent traumatic event, etc. And the sleep environment, as I guess Dr. Naka said, and sleep time such as the bedtime, duration until sleep onset, final awakening time, consistency of these bedtimes, nap times, nap lengths, and the patient should be asked for the number and duration of awakenings over a typical 24-hour period or a week. And it might be hard for a few patients to like actively recall, and it might be difficult to like actively like answer all your questions. So for those sort of patients who cannot recollect, they might be asked to fill a daily sleep log for about a week or two, and they should record the sleep times, the sleep problems they have, and the subjective sleep quality, so that we can review it and diagnose it accordingly. The most important thing is to actually look at the medication list the person is taking. Any guesses on which medications could affect your sleep?
Stimulants, maybe amphetamine.
Stimulants. Yeah.
Right. So stimulants and sedatives both. So these are the ones which can cause insomnia. Basically, they are the stimulants, and along with H1 antagonist and statins, which a lot many patients might be using. So it's necessary to rule this out as well if they've recently started it or stopped it or any of it, including barbiturates, beta blockers, antipsychotics, and anticonvulsants. And once you have a rough idea of what the sleep disorder might be, it might be useful to ask certain questions to like kind of get to the root of it, or you can like finally say, yeah, this might be it. And these are just examples of a few questions you could like ask. So louder habitual snoring, witness apneas, you think of obstructive sleep apnea. Leg discomfort, you or if the partner complains of limb movements during sleep, you signal a you kind of think of a sleep related movement disorder. If there's cataplexy, sleep attacks, you think of narcolepsy. And an important thing is to interview family members as well as the spouse if they've noticed anything important. Accessing relationship with the spouse or the others in the family, the ability to concentrate, work productivity, and mood is also important because that can indicate an underlying sleep disorder as well. So physical examination. What do you guys think you will see in a physical examination though?
Dr. Knock, you don't speak up. Other people, I want information from you. What would you see? What would you look in a physical exam for?
Thank you.
A thick neck, obesity maybe, that could be telling.
What else?
Maybe striae and Cushing disease, or one who are taking corticosteroid.
I'd be also thinking about psychomotor retardation or agitation.
Yeah, you could.
Maybe a tremor if it's a REM sleep disorder.
Nice.
You can use a flashlight. What do you do with your flashlight? What?
Try and induce a seizure.
I would open the patient's mouth and take a look at the airway.
Yeah.
Yep.
That's fine.
Yeah. So in some cases you would definitely find, but in a lot many cases you might not find anything. But noticing certain things like falling asleep while waiting for the clinician, excessive yawning, difficulty keeping eyes open, and poor concentration may also help support the history. This does not, if these signs are not present, does not specifically exclude excessive daytime sleepiness, but these are just the signs you could look out for. The other things are like, for example, if the patient presents with obstructive sleep apnea, right, you see excessive oropharyngeal tissue, retrognathia, large neck circumference, and obesity. And like Dr. Stein said, you could actually find the crowded airway as well. So these are just a few things you should keep in mind. Like since there are so many diagnoses we could think of, there are a lot many things you could actually even find on physical examination. But the important thing is to know that if we, even after clinical history, we assume that how do you quantify the sleepiness of the patient? So we have a combination of subjective test, objective test, along with the history. But the important the initial test, and it's a questionnaire which you get, which the patient fills out. Actually, I'll also, especially if you're suspecting narcolepsy and idiopathic hypersomnia. I think Dr. Burnett talked about multiple sleep latency test on one of the Saturdays, I guess. And the maintenance of so this is an example of the Epworth sleepiness scale. So the patient is asked, how likely are you to doze off or fall asleep in the following situations, ranging from no chance to high chance. The interesting questions are here. As a passenger in a car for an hour without a break, I would definitely fall asleep, especially if I do not have my phone on. And then in a car while stopped for a few minutes in traffic. Now, many of you might answer a moderate or slight chance to these, but so any score from 0 to 10, is basically normal, so it's okay. But anything from 10 to 12 is borderline, you should suspect, and anything above 12 to 24, a patient is more likely to be having a sleep deficiency or a sleep disorder. And polysomnography is the one which we mainly refer to as sleep study. And so that is the important one, right? And so most common indications for polysomnography is for evaluation of sleep disorder breathing disorders. So that includes obstructive sleep apneas, kinds of breathings, even central apnea, concurrent COPD as well, even titration of the positive airway pressures, and the assessment of adequacy of the current therapy the patient is taking as well. So it's an important test for follow-ups as well. And it can also be a part of diagnostic evaluation in patients with periodic limb movements, parasomnias, REM sleep behavior disorder, and obviously excessive daytime sleepiness, other causes of it. And the polysomnography may also be combined with an EEG when nocturnal seizures are suspected as a part of differential. When a person has, for example, a patient has a leg movement disorder and you might suspect a focal seizure, it's important to do an EEG as well to like just confirm or rule out a seizure. So this is the basic setup. So there are multiple electrodes monitoring the brain activity along with muscle movements. There are belts which monitor the breathing, and the nasal cannula monitoring the airflow, and other such electrodes. And this is what basically a polysomnogram would look like. This is just an example of the N1 stage N1 of sleep. And these are the eye electrodes, the chin electrodes, this is the frontal, central, and the occipital electrodes. This is the ECG, and this is the right leg light and the left leg electromyogram. And this is when the patient kind of briefly got up, since this is just the stage N1 sleep. And now I'll just briefly talk about a few conditions, common or interesting ones. So this is I'll talk briefly about narcolepsy. So there's type 1 and type 2. So narcolepsy type 1 is with cataplexy, type 2 is the one without the cataplexy. It typically begins in teens, but also seen after 40 years of age. The etiology is loss of orexin, certain genetic factors, and rare brain lesions as well. The classic tetrad is chronic daytime sleepiness with varying amounts of cataplexy, hypnagogic hallucinations, and sleep paralysis. And we saw this patient 2 Saturdays back, I guess. Yeah. So all patients do have sleepiness, but only 1/3 of the patients will have all of these symptoms. And we were lucky enough to see a patient which had, like, I guess all of them. Yeah. And so diagnosis is mainly polysomnogram, but that is to rule out other sleep disorders. The important one is the multiple sleep latency test in this particular condition, which demonstrate an average sleep latency of less than 8 minutes, that the patient falls asleep within 8 minutes and or at least 2 sleep onset of rapid eye movement periods, which our patient did have. And the other diagnostic measure is measure the orexin A or hypocretin 1 in the CSF. It's also useful when the multiple sleep latency test is negative, maybe because the patient did not sleep well, or maybe the patient was disturbed the night before. If you're suspecting anything else, you might get this measure as well to just confirm narcolepsy. So insomnia is the most common one, which all of us are familiar with. And the important thing is it is difficulty with sleep initiation, maintenance, consolidation, or quality that occur despite the adequate time and the opportunity for sleep, and results in some form of daytime impairment. And it can be acute or it can be chronic. If it's acute, you usually think of psychologic and physiologic stress factors and the medication review as well. And the chronic ones usually tend to have a lot of multiple factors in it. So you would ideally do cognitive behavioral therapy and pharmacotherapy. Those are the main treatment options for chronic insomnia that persist even after you deal with the underlying factors. And to identify these factors, like we mentioned, sleep history, it should include social, medical, even psychiatric events, as well as the medication list is of utmost importance. And just quickly talk about obstructive sleep apnea since it's so common. And yeah, sorry, I forgot to ask you. This is the questionnaire which we all have very familiar with, especially the guys who've taken the USMLE. the stop bank questionnaire. It asks about the snoring. Is the patient tired? Are the apneas observed? High blood pressure, body mass index, age, neck neck size. I think 17 inches for male and 16 inches or larger for females, and it's more prominent in male. So any yes to any of two questions, it indicates low risk, and 5 to 8 questions is very high risk of obstructive sleep apnea. So the interesting thing to note is they could present with any symptoms, as simple as just lack of concentration, nocturnal restlessness, or just snoring, which most of the people do, but it's a particularly loud snoring. The partner would definitely be affected, most likely. And in examination findings, you would find the crowded airway, obesity, large neck circumference, and retrognathia. And the diagnostic test you would do is a polysomnogram. You also have the patient also has a choice of home sleep apnea testing, or he could do an in-hospital testing as well. So this is just a list of associated conditions. Like, as you can see, it is associated with so many medical conditions. It would be present in anybody's clinic, I guess. And thus, I feel it is so important to keep obstructive sleep apnea in mind, especially dealing with elderly patient. And if the patient is not dealing well with multiple conditions, you should obviously look into obstructive sleep apnea and treat it. So the conditions would be systemic hypertension, cardiovascular disease, end-stage kidney disease, lung disease, pregnancy, hypothyroidism, even Parkinson's. Like, as you can see, it is associated with a lot many conditions. And this is what I wanted to share, that it's good to have a good approach to sleep disorders. So you kind of keep things in mind and treat it accordingly. Just a few references. And yeah, hope this is not the state of anyone right now.